Good afternoon and welcome. My name is John Coatsworth. I'm the acting dean of the School of International and Public Affairs here at Columbia. I've become a specialist in introducing controversial speakers, but I'm happy to say I don't need to use any of those skills this afternoon. And I'm delighted to welcome Mike Leavitt, who is the Secretary of Health and Human Services in the United States government, to Columbia. Michael Leavitt was sworn in as the 20th Secretary of the U.S. Department of Health and Human Services on January 26, 2005. As its Secretary, he leads the national effort to protect the health of Americans and provide essential human services to all those in need. He manages one of the largest departments in the federal government with a budget that accounts for almost 1 out of every 4 federal dollars and more than 67,000 employees. Makes my job look easy. During his first year, he led efforts to successfully enroll tens of millions of seniors and disabled persons in the new Medicare prescription drug benefit program, mobilized the nation for pandemic preparedness, accelerated the development of health information standards, and oversaw the medical response to Hurricane Katrina. He also presided over changes in Medicaid statutes to give states flexibility to provide targeted insurance coverage to more people, and the reauthorization by Congress after 10 extensions of the temporary assistance to needy families. He came to Washington after a successful career as governor of that state. He's still missed by many of his fellow citizens that I've talked to, and he had, I'm reliably informed by experts in this building, an extremely successful career as the director of the Environmental Protection Agency. Today, I'm pleased to welcome him to Columbia. His talk is entitled, Every American Insured.
Well, I'm glad to be here to spice up an otherwise uneventful week here at Columbia. Let me just confess to you up front that I really like the classroom, and I'd like to treat this as a classroom and have interaction with all of you. I have 15 or 20 minutes of what I hope will be adequately provocative material that I can inspire a question or a comment or a challenge. And I'd like to reserve the majority of our time for that kind of thing. There are really 4 major points I want to make today. Let me just tell you what they are, and then we can get down to discussion of them. The first, I want to talk about health care in general, but I just like to acknowledge that the anxiety everybody's feeling is warranted. This is a big problem, and it's going to require some serious focus, both socially and politically, and I will add, parenthetically, economically. It is the kind of problem that if it's left unchecked could erode the solvency of a great economy. It is the scale of a problem that could undermine prosperity. It is already redefining our nation's macroeconomic equation. We're seeing substantially less money, I believe, that going into education, into things like innovation, R&D, investment in other areas because of the flow of funds and economic value into health care. So that's the first. The anxiety is warranted. The second major point is I'd like to talk about the shape of our health care sector. It's my view that health care is not a system, it's a sector. And I want to defend why I believe that and what I sense we can learn from it and how we can shape it into a system. Third, I'd like to talk about that it's more than just a system change that we need. It will require a change in ourselves to solve this problem. And lastly, I do want to talk some about the importance of every American having insurance and being part of the system of health care that I believe is beginning to emerge. So let's go back to the first point. The anxiety is warranted. Let me just say that you undoubtedly feel this yourself. Most people do in one way or another. If you are a worker and you get a paycheck, It is not uncommon now to get a raise and find that over the course of time the raise didn't raise your top line but not your bottom line because the raise is eaten up in increased health care costs. That gives people anxiety because everything else continues to go up. It's certainly being felt by businesses who are struggling to meet the needs of employees and to maintain a competitive position in a global marketplace. I honestly don't believe there is a boardroom topic more consuming than this issue. Today, GM workers have gone back to work after a 2-day strike over this issue. Is not the first, it will not be the last. There is enormous anxiety on this subject in the business world. You see it among healthcare providers. If you're a doctor or a hospital, this is the issue that defines whether or not you have a practice model that will allow your continued service to your patients. It's worrying economists, and I believe it should. I was born in 1951. I'll save you the math. I'm 56 years old. But when I was born, healthcare was 4% of the entire economy. Now, my wife and I have 5 children. When our first was born, 25 years later, it had doubled from 4% to 8%. And not long ago, we had that great moment where we walked into a hospital room and saw our son holding a baby of his own, and it had doubled again from 8% to 16%. Now, that progression can't continue if we intend to be a leader in a global economy, particularly since the health results that spending is achieving is not particularly good by comparison to the amount that we're spending in relation to others. Obviously, this is beginning to catch the attention of the political candidates who are positioning themselves to run for president. Everyone is now coming out with a plan. That's a positive part of the discussion and the debate, and I think we can expect that it will be a big part of public discourse between now and 2008, as well it should. But I would like to say I believe we've got to spend more time, not just on how we get people insured, but how we use that system to begin to manage costs. So that's the first point. The second point then is, do we really have a health care system? I will argue today that we don't have a system. What we have is a healthcare sector. It's a big, robust, rapidly growing healthcare sector, but there's nothing about it that really would qualify it as an economic system. We are surrounded by systems. Most of you are carrying a system on your hip. It's called a cell phone. You buy your minutes from one vendor or another. You buy your cell phone from another. But somehow they have all come to use the same system to optimize the value they provide us. They compete for our business, but they use the same system in order to optimize value. I flew here on an airline. Airlines competed in an economic system for my business. They have rates, they have fares, they have service that they compete on, but they all use the same system to optimize the value that they provide us. Banks. I have a bank card in my pocket. It's blue. Yours is probably red. Different banks. You chose yours. I chose mine because of different competitive advantages. But they all use the same system to optimize the value that they provide. Nothing like that in the healthcare sector. Now, let me use a personal experience that I believe begins to refine what a healthcare system would look like and what the absence of it produces. Now, if you'll excuse a personal experience, I mentioned that I'm 56 years old, and when I turned 56, I was reminded that I needed to get one of those over 50 tests. Yes, I'm talking about the colonoscopy. And I got one when I was 50. And I don't remember a lot about the experience. I just went to the doctor, I gave him my insurance card, and just sat back to endure the experience, and it turned out all right. Well, this time, 2 things had changed. One is I am now Secretary of Health, and the second is, in the meantime, I had purchased an insurance product that allowed me to share in good decisions, referred to as a health savings account. So this time I called the doctor and said I need to have a colonoscopy, and I called 2 doctors and said how much will they cost. And to my surprise, both of them gave me the same response: we can't tell you. What do you mean you can't tell me? Well, you just come in, we'll give you the colonoscopy, we'll figure out how much health care you used, and we'll work it out with your insurance company. Well, that just felt unsatisfying to me. So I decided I'm going to go on a little field trip with this. And I went back to the Department of Health, and I brought 2 or 3 physicians in who could help me, and I said, let's define what you in the business call an episode of care. Now, this is a little bid sheet on your colonoscopy. And I called the doctors back, and they gave me line by line what it would cost. I was surprised, first of all, by the cost. Now, the first one was $6,500. The second one was $5,500. I had no idea what it cost. I have no idea what it cost when I was 50, because I just gave them my card and they took care of it. Well, I went home to see my wife, who is also my age, and we decided, and she needed one too, and I said, this is serious money. Why don't we call out to Utah, where our children are, and find out when we go out to see the grandkids, maybe it'll be cheaper out there. And so I called. It was, in fact, just under $3,000. Big difference. Then a really interesting thing happened to me. I began to wonder, is there some difference between the $6,000 version and the $3,000 version? I mean, we all want high quality. I mean, if you're going to get a colonoscopy, you don't want to cut any corners, right? So I am. Then I realized this. Wait a minute. This is exactly what the system can't accommodate. If I begin to equate quality with cost, I'm creating a perpetual cycle that will drive costs up and will have no reality to how good it is. There needs to be a way of measuring relative value. Now, what I've just described is competition. Competition based on value. Value being the combination of price and quality. Wouldn't it be a lot better if I didn't have to figure out on my own as a consumer a basket full of services that I could compare? If we had standard episodes of care that I could compare. Wouldn't it be a lot better if I had a way of comparing those episodes of care with quality? A standard of quality that someone reliable in the medical industry or the medical industry had developed. Wouldn't it be better if I didn't have to make all these embarrassing phone calls to be able to get the information? Well, what I've described for you is a system of competition based on value, where consumers have information about the cost and the quality, and everyone in the system has a motivation to choose higher quality and lower cost. Now, that is a system of competition based on value, and I believe that is the means by which we are now beginning to shape our system of health care. Now, let me just say that how we get from where we are today to where we hope to go, there are 4 what I refer to as cornerstones. The first is electronic medical records. A lot is talked about on this point, but we're working very slowly through a process to get there. Second would be having quality measures that the medical industry, the medical sector has defined as a quality colonoscopy or a quality anything. And third would be these episodes of care, and fourth would be the ability for incentives. So let me talk just for a second, if I could, about the shape of the way I think electronic medical records change the way we interact with health care. A lot's said about electronic medical records, but it tends to break down into 2 different competing points of view. One has a heavy practitioner view. This is a clinical record that records all of the results in a way that the doctor or the hospital can look to check to assure that there are no competing or events that would have adverse effects. It's a way of being able to maintain medical histories in an orderly way. That's very helpful for the physician, but perhaps not very helpful to the patient. The personal health record tends to be the place where a consumer begins to find value. How? Well, I had a woman who works in my office say to me, I've got to take my twins to the doctor, so I'll be gone tomorrow. When she returned, I asked how it went. She said, well, I spent half a day as a medical courier. I had to go from doctor's office to doctor's office, picking up big brown envelopes to take it to a third doctor who could interpret them. And she said, it frustrates me that I can't just say to my doctor, would you email those results to the other doctor? But we're not able to do that, she said, because the systems aren't compatible. Well, a personal health record would be a means by which a patient could keep all of their health records in one place so that they could be managed. Because the clinical record at the clinic might not have access to the records at the hospital, and the hospital might not have it at the pharmacy, and the pharmacy might not have, and the record may not have it at the lab. So what I see unfolding in the future is that I believe most consumers will have a personal health record, but it won't be the kind of system where you have to put them there yourself. It will ultimately be a system where you can tell your personal health record, these are my records, I want to manage them, here are the 11 places I go for health care, and I can authorize my personal health record to go off to the clinical record base of my hospital or my doctor or my lab and bring back to my personal health record the information that I have and want to keep. So if I go to see a new doctor, I won't be handed the medical clipboard. I'll be able to simply say, here is the access to my information, I control it, here is my name, my address, my insurance company, here is the lab test I had, the image that I had run, etc., etc. Now you can begin to see how that would create an advantage. At the same time, I believe we will see the equivalent of Travelocity for health. Now, I don't know if any of you are familiar with the program Quicken. Quicken is basically a management of a checkbook. It started off, Quicken essentially required a person to go in and put their own checks in. Then they worked it out with the bank so that the bank could send the information to Quicken and populate it for them. We're in that phase where I think we'll very shortly get to the point that we'll have the medical equivalent of Quicken and the medical equipment of Travelocity, and it will begin to streamline into this system of competition based on value so that at some point I can go on the internet, have my medical records, and say, this is the kind of thing I need, where can I find it, how much, who has the best, and what is the cost. I mean, that will be a dramatically different system of competition based on value. All right, let's go then to the third point, which I talked about, which is this isn't just about changing the system, it's about changing self. May I say this is both bad news and good news. Let me give you the bad news first. Bad news is we have 10 million children now who are overweight or obese. That's 1 out of every 5 children. The bad news is we have seen in the last 25 years a tripling in the number of children from 6 to 12 who find themselves in that category. The bad news is we still have 50 million Americans who smoke, and who do so still knowing that half of them will have premature death or disability as a result of it. The bad news is that we have seen in recent years a 70% increase among those who are 30 to 39 who have diabetes. There is clearly something happening here that has to be responded to. All of that adds up to the fact that we have 75% of the entire $2 trillion healthcare market that is now 16% of our entire economy is in a category called chronic disease. It is eminently manageable and it is eminently preventable. Now, the good news in all of that bad news is that we could change it. It would not require an act of Congress. It would not require a regulation at the Department of Health and Human Services. It would simply require a change in behavior. Now, that comes harder, but it's eminently producible. Now, I promised myself that I would never talk about health care without making this point, because this is about people, about what makes up a nation. A nation isn't just its government. It is the aggregate of the behavior and the hearts of its people. We're seeing a 30% or 70% increase in diabetes among people who are 30 to 39 because people are not doing basics. We're not seeing physical activity among adults. 60% are not physically active enough. We're seeing that kind of news because we are not eating well. We're not getting the screenings that are available. We engage in a lot of risky activity. My point is that this cannot simply be economics. It cannot simply be politics. It has to be serious sociology. And if it isn't, we will begin to see we'll continue to see our country's health trends move this direction. We will see the inevitable impact that it has on our productivity. And when our productivity begins to falter, we'll begin to see the siphoning off of economic resources to take care of it, and we will begin to lose our competitive position in an economic marketplace that we have maintained for over 100 years. So this is a very serious sociologic, economic, and political subject for that very reason. But it is not simply about change of system. It is about change of self. Now, lastly, I just want to touch some on access to the health care system in whatever form it is. I'm talking about the need for every American to have health insurance. This is a widely held aspiration. The political parties tend to talk about it in different ways. If you're a Democrat, you really like the word universal. If you're a Republican, you're more inclined to the word every. But nevertheless, we're all headed to the same goal. It is not the goal that divides us. It is the pathway. Now, for 50 years and beyond, we have seen this same debate of a collision between two quite divergent philosophies. And it really boils down to a question not of whether or not government ought to have health insurance, or people ought to have health insurance, but what is the role of government and what is the role of the individual. This is a debate that has dated back to 1787 at the Constitutional Convention, and it continues to go forward, but it is very much in play here. One group believe that government has the role of essentially owning the system, that we ought to have government describe the benefits and choose the plan, that government ought to set the rates of reimbursement, that government ought to pay for it by taxing the people and providing it. Other people believe that the system isn't to be owned by the government, but the government has an obligation to organize the marketplace. Now, I would suggest that in between those two is likely where we will begin to see a real solution, that it will be a need for us to blend the values of every American having health insurance with the ideology that the private sector can provide it in the most efficient way, with the value of some form of standards with the idea of flexibility. And I want to talk a little bit more about that. Perhaps the most current issue where we've seen this highlighted in a very real way is the state children's health insurance plan. Now, this has been a very successful program. It insures about 6 million low-income children. And we have chosen in this country to define low income as those who are at 200% of the poverty level, or about $42,000 for a family of 4. Now, it currently needs to be reauthorized by Congress. And there's a disagreement, not about whether it should be reauthorized, but what the true focus of this program should be. There are those who believe that government ought to be insuring, as a government, more people, and therefore we ought to expand this program to cover more people in higher incomes. There are those then who, and I am among these, I should share my bias, that this program is a very important program and it should focus on those who are poor. That debate is now finding its way into Washington, and I have used the time I said I would use to be provocative. I'm going to leave it at this, and then if you have a question and would like to talk more about S-chip, just raise it, and I'll use the time that we allotted together to explain why I think that's how this frames up. Well, with that, have I done enough to inspire a question or a challenge or some discussion? Who would like to raise the first topic? Yes, ma'am. Could you speak just a little bit louder? I can't hear you. Oh, we have microphones over here, and I think it's because it's being webcast, and otherwise I would simply...
Hi, I'm Maureen Farrell, and I'm with Forbes. I'm a reporter with Forbes.com. You mentioned the 200% poverty level, and I know you've said in the past that you don't think CHIP should cover families with incomes above 200%. Do you think that's still a relevant measure when we see that premiums are rising so much quicker than inflation?
Let me say a couple of things in preface of my answer. First, again, I want to emphasize, I think every American needs to have access to insurance, and that the real problem we ought to be focusing on as a country is how we get everyone access to an affordable basic insurance policy. My own view is that if you are elderly, disabled, or poor, that government has an obligation to offer you insurance and to pay for most of it. Now, the question we have to define is where do we draw those lines? Congress in the past has said $42,000 for a family of four is where we will draw that line. The bill that passed the Congress that the President has said he would veto would raise that from $42,000 to $83,000. Now, what's the impact of that? Well, the first impact is that it means that about 71% of all American children would be receiving public assistance. It also means that many people who currently pay what's known as the AMT, or the Alternative Minimum Tax, it's a tax that was designed to make certain that rich people pay their share. Many of the people who would now be eligible for S-chip would also be required to pay the rich people's tax, the AMT. Now, only in Washington could you be rich and poor at the same time. Now, what do we know about the people who would be paid for, have their insurance paid for by S-chip? Well, first of all, the proponents say that it would be 4 million additional people. I want to unpack that number for you. Of the 4 million, 1.2 million are already eligible for Medicaid. All they have to do is sign up. 900,000 of the 4 million are already eligible for S-chip. All they need to do is sign up. Now that leaves us with 1.9 million people who the bill would now expand to. What do we know about them? Well, we know all of them make more than $42,000 a year, and that if they make between 42 and 83, that over 70 and under 90%, somewhere between 70 and 90% of them already have private insurance. So what this in effect would do is take a large group of people who already have health insurance, move them from the private insurance market to the government-funded insurance market. Rather than being a bill that is focused on taking people who are uninsured and helping them get private insurance, this takes people who are already insured and moves them to a government-paid health insurance program. So again, we're back to the question. Should government be running or owning the health insurance business, or should we be organizing the health insurance business? My view is that we need to reauthorize SCHIP so that it continues to fund the needs of poor children, and then we need to use our capacity as government to organize the marketplace so not only 75 or 80%, but every child has access to an affordable basic plan, and if they're not able to pay for it, we ought to do like we do in every other human service, help people make up the difference. Now, that's the discussion we need to be getting on to now. Let's acknowledge the fact that everyone in this discussion wants SCHIP reauthorized. Everyone wants children to be insured. This is down to a question of what is the role of the government in being able to create a system. Yes, sir.
I have a couple of questions. First one is, in the past, I understand that any any presidential candidate taking health issues in campaign are considered to be political suicide. It's a very complex issues. No one can hardly talk about this. With regards to three past health proposals by your former predecessor, Secretary Joseph Califano. Another one is Hillary Clinton's 1993 reform proposal, and her current proposal. What is the difference? Another important issue is since Clinton administration's new program, HMO program, I think that's Clinton's program, HMO system. In addition to other programs, the American total administrative expenditures of total healthcare is something like 35%. If that is the case, going back to the old traditional fee-for-service basis, with the government guidelines regarding the cost guidelines, whether those 35% of administrative cost may have some kind of solutions to these problems. As you know, the HMO executives make millions of dollars, at least in some programs. So considering overall issues, whether the old system of fee-for-service at the expense of removing the administrative cost of something 35% is maybe feasible or not?
Thank you. There's a whole series of items there. I'm going to sort of roll them into one and do my best to be responsive in the general category. I'd like to tell you how I believe this problem can be solved and how we can get to a point where every American could be insured. There has been and will continue to be, I think, a great sense of reluctance to see the federal government provide all health insurance. I think that is intuitive, personally. I think the world is beginning to organize itself into networks, and that anything that replicates a 1960s or 70s mainframe computer as opposed to a network of PCs is not going to be viewed as providing the level of flexibility and adaptation that's necessary in our world. And I believe we'll begin to see a system that resembles a network of PCs more than a mainframe one-size-fits-all. How does that come about? Well, the action right now is in the states. Massachusetts has embarked on a very aggressive model. Governor of California right now is trying to get a program through. Same thing is happening in Texas, it's happening in Kansas, it's happening in Florida, it's happening in a whole series of other states. The states are hungry to solve this problem. They, however, have a problem they cannot solve, and they cannot get to a solution until they have this problem solved for them. And it is the problem of the blatant discrimination that occurs for people who don't buy their insurance through their employer. Just a little bit of background on how this system started. No one decided legislatively that employers ought to be the purchase point for insurance. It happened in the 1940s during wage and price controls when employers were attempting to keep good employees but couldn't raise their salary, and so the court ruled that they could in fact start providing benefits like health insurance. Consequently, the system has grown, and it's become a very important part of the way we deliver it. And my comments are not to be interpreted as I believe we ought to do away with that. I just want to recognize that it's an important part of the system, but it grew up sort of intuitively. The problem here is with the person who is a waitress or a teacher's aide that doesn't work enough hours at the local school district to get benefits and married to a person who works for a small business and they don't offer it. They make a pretty good living on their combined salary, but neither of them can buy it through their employer, so they have to go out and buy it on their own. And they buy it at higher than group rates, and they have to pay for it after they paid their taxes. And so they miss out on the biggest tax break that the tax code gives to any American, the ability to not have their health insurance charged as income. And they just can't afford it. So if you're a governor, I was one for 11 years, I took several runs at this problem, and you come to I've gotten to the point I can go into a state now and work this formula on the back of an envelope. You can't solve this problem until you have that dilemma resolved, because people simply cannot buy insurance as efficiently as if they are buying it in after-tax dollars and part of a larger group. So what we're seeing is that states are beginning to try to solve the problem, but they need Congress to solve that dilemma. Now, there are several proposals on the table. One would use what's known as a standard deduction. This is a proposal the president made. Another would be using an earned income credit. A lot of people like that. The earned income credit, for example, would allow 20 million people to buy insurance that have not purchased it today. That's a huge number of people. So we ought to solve that problem. And if we solve that problem, and there are many proposals to do it, it not only would allow 20 million people, but it would cover about 3 times or 4 times the number of children who would be covered under the bill the president will veto. So I would say we have to solve that problem. The second thing that has to happen is that the states then have to be unleashed to solve a problem called the pooling problem. They've got to find a way for every person, no matter their health condition, to be able to buy insurance. Now, there are several different ways in which that could be done. In Massachusetts, they've used what they refer to as the individual mandate, where they require everyone to buy it so that it's not just sick people who are buying insurance. There are other ways to solve that problem. But every state needs to step up and have a deadline as to when it is that they will solve that problem. So if you combine the tax discrimination being eliminated, so everybody has a level playing field, each state organizing their market, and then the federal government partnering with the states to take care of those who have special needs, you are at a point where you have provided access to coverage for every American. Now, I believe that will happen a long time before we'll see Congress create a one-size-fits-all Medicare for all program. And we ought to get on with it. I believe in a relatively short period of time we could see every state organize their market if they're given the tools and they want to do it. So I hope I touched on most of the things you raised. Yes?
Hi, my name is Dan McIntyre. I'm an Associate Dean here at SEPA. Thanks for speaking here today. I wanted to ask you to talk a little bit more about the increasing cost of healthcare. You described how, since basically you and I were both born, I believe you said the percent of cost as a share of GDP has quadrupled. Can you talk a little bit, I'm going to ask this two different ways, in general about why that has occurred, and then specifically I'd like to ask to comment on a specific healthcare. I heard a fascinating report this morning on National Public Radio about a suit against an insurance company to include autism treatment as a diagnosis and a treatment that should be covered within insurance. So sort of generally why cost of high healthcare has increased, and then specifically how new costs or new forms of treatment get added, and that autism one as an example.
Let me just generalize on the why it's gone up. It's you and I could do a book together on that subject, but it's essentially a combination between demographic, economic, sociologic, but in my mind it all centers on the fact that that healthcare is a sector, not a system, that there's no way to begin to make managed decisions. Now, once you use the word managed decisions, then you have to ask this question: who should make decisions for a person on their health? Somebody's going to. Or you have a true runaway. The three choices. The government could make them. The insurance companies could make them. Or the consumer themselves could make informed decisions. Now, our system today basically relies on a combination of government and insurance companies to make those decisions. Consumers are not provided the information that they need. I'm not talking about the medical prognosis decisions. I'm talking about the priority decisions. I'm talking about the decision I talked about with my colonoscopy. No transparency of quality, no transparency of cost, and all of the incentives run the wrong way. If I'm a healthcare provider and I want to buy a new scanning machine, I get paid for that by doing what? More scans. The system is oriented completely to pay for more. The system is currently organized in a way that it rewards the highest cost. Until we reverse those and create a competition based on value, where people know the value and can make choices based on that, we will not see a reversal of this trend. No government bureaucracy is able to manage in a way that does not take from the consumer the decision, all of the various iterations of the decisions they need to make. Can I give you a great example of this? The prescription drug benefit, Medicare Part D. All of you saw the overspray of the commercials and all. We enrolled tens of millions of people in that in the last 2 years. It was controversial. For years, people said we need a prescription drug benefit, and one side said, let's have the government provide a one-size-fits-all plan. Let's just make it part of Medicare. Let's have the taxpayers pay for it. The other side said, no, let's have it handled in the private market. Neither side could come to a conclusion, so we ended up with I think, a very good mix. We used the government not to own the system, but to organize the system. And we created a basic plan, and we said to the marketplace, go out and come up with different iterations and different innovations, and then offer it, and we'll help subsidize it. Well, people said, folks are never going to like this. They won't buy it. Well, today we have 92% of all eligible people who have enrolled. Now, Medicaid has been with us since 1965, and we still have 50% who have not enrolled. Part D, we have 93%. People said they're not going to like it because it'll be complicated and they'll have to make a decision. 80% say they like it. They say they like it and they're happy with their plan. And the good news is if they're not happy with their plan, they can choose a new one. Because there are people out there trying to innovate and say, come do business with me because I'll do a better job. And what's happening? The quality is going up and satisfaction is going up. What about the price? We started out estimating that this would be $37 a month per consumer. Today, This year, we delivered it for $22. Ask economists and actuaries why that happened, and they'll use one word: competition. When competition is in the marketplace in health and people have transparent information about cost and about quality, the quality goes up and the cost goes down. So if we want to have that kind of an impact on the overall system, we've got to provide, government needs to organize an efficient market. Government has a role of setting the rules. Government has a role of healing the inequities. Government has a role of subsidizing those who need extra help. Government doesn't have a good role in owning the system, because when government owns the system, we begin to control all of the decisions, and we control them by lengthy, arduous, costly, frustrating regulatory rules that take forever for a logical, thoughtful change to be made. Medicare, which I manage, every year has to publish a rule on how we're going to price 10,000 different procedures. I walked through a wholesale grocery warehouse the other day. I said to the man, "How many items are in this warehouse?" He said, "There are over 100,000 different items in this warehouse." I said, "What would happen if you had to go through a government regulatory pricing scheme to decide how much each of those would cost and how many you ought to order? And you ought to have a way of authorizing." He said, "Well, obviously it would bog things down and it'd cost a lot more." Well, healthcare is much, much more like food than it is any other government function. I mean, the truth is, we're trying to decide in this country whether healthcare is more like national defense, government-owned, or more like the food system, government-organized. I mean, think about food for a second. Everybody needs food. We don't want anybody to go without food in this country. So how do we organize it? Well, the government has policies that say everybody needs access to it. It needs to be abundant. The government has policies that say we want it to be inexpensive. The government has policies that say we want it to be safe. But we still expect people to go to the grocery store. We still expect people to pay for it. But if they can't, what do? We give them food stamps to help those who can't afford it. What if they can't even get to the grocery store? We organize Meals on Wheels. We take it to them. But we don't create a system that owns the whole system. That is a model that will fail and will produce dramatically more complications and will not bring the cost down. It will simply make the costs go up. There is no question in my mind, you look at healthcare systems all over the world, what you'll see are long waiting lines, higher costs, and taxes. Now, there are those that can deliver public health on a mass basis. But if you go to any country in the world where there is a highly socialized system, you'll see a fairly high satisfaction on the delivery of basic public health. But you see a lot of unsatisfying outcomes when it comes to, can I get a hip operation? What about the need for heart, et cetera, et cetera? You must be telling me it's about time to quit.
It's about time. I think maybe we have time for one more
All
question,
right.
if you'd like.
Good. Why don't we go to, this is so hard. I'll take these two, and I'm going to take the gentleman and then the woman, and I'll be short, and maybe after I can respond to your questions as we leave.
Thank you for being here. My name is Chris Lavelle. I'm an MIA student. It shows a lot of courage to come here. Surely this is not the friendliest territory for you, so thank you. I'm Canadian. I grew up in a system with government-controlled healthcare. I thought it was pretty good, but I don't want to debate personal views. Hendrik Hertzberg has a piece in this week's New Yorker, and I wonder if I could just put it out in reference to what you said. You said that when the government controls the system, costs go up, results go down. His stats, I think the OECD backs them up, and I'm reading here, we spend twice as much as the French and the Germans, and 2.5 times as much as the Brits, and yet Americans die sooner, and our babies die in greater numbers. It seems like on the face of it, you get better results for a lower cost with the government-run system. What's the counter to that? That seems incontestable.
Well, I think you'd have to go back to what I said. It isn't just the system. I think you'd have to look at the healthcare trends, because what's driving our costs for the most part is the way we live. It's the fact that we've had that tripling of number of people, 30 to 39, who now have diabetes. And we'd like to be able to point to the government and say, well, that's the government's fault. That's not the government's fault. Those are decisions we all individually make. And secondly, I'd like to say that I believe the reason our health care costs are growing is not just the way it is the lack of constraint. And in those socialized countries, socialized systems, I don't mean countries, correction. In those socialized systems, you have a government that has stepped forward and said they want to make the decisions and to the extent that let me just say what I believe that kind of a system is. That kind of a system is you put up a budget and say, here's how much we're going to spend, and we want the system to provide as much health care as they can. And in most cases, I don't know about the Canadian system specifically, but in most cases you find practitioners who work for the social system in the morning have a practice in the afternoon. And you can go wait in line for the social system, or you can pay extra money and get in immediately in the afternoon. It's a question of who do you want the decisions to be made by. Do you want the government to make it? Do you want the insurance companies to make it, or so the consumers make it? I believe our current system is the worst combination of insurance companies and consumers making it, and it would be a far superior system if we had the ability for consumers to make it. The lady behind. I know we're going to see her afterward. Yes, let's take your two questions. I'm sorry, that's all I can do because of the time, but I'll try to.
My name is Eric Colchimero. I'm a student at the Wagner School down at NYU in health policy. I was hoping you could expand, since we only heard briefly toward the end, about the Bush administration's current thinking on S-chip. The $83,000 figure that you quoted, I was reading a few articles this morning, and that seems a little bit questionable by a number of Democratic sources who said that figure only is for the state of New York and doesn't apply on a national level. The recent CMS restrictions on Medicaid reimbursement, I know you received a bipartisan letter contesting that, but I don't know if there's going to be any action as a result of that.
Why don't I take those two, because I think we're...
Well, it's just on the related
okay.
point. And then the bill that's about to get past the $35 billion, it has the votes to get overridden in the Senate. It's missing about 15 votes to get overridden in the House. It seems like it's a bipartisan issue. Senator Smith, Republican from Oregon, Senator Hatch from Utah, Representative Wilson from Nevada. It just seems like the Bush administration is out alone on this, and I was curious, a little more of your thoughts.
Okay, and I'll try to respond to all of those. First, the 83,000. It does specifically apply to New York and a couple of other states, but what you find when you get into the fine print of these things, it allows the states then to define income the way they would like to. So if you don't like 200%, you can say, let's call it 200% and exempt rent, and exempt a lot of other things that allow that to be, or 300%. You can get it very easily to 400, and states will. With respect to the guidance letter, basically we said we've got a limited amount of money in this because this is an allocation, not an entitlement. And we want poor children to be put at the front of the line as opposed to better off children. And we want states to do the hard spade work, and it is hard, to find children. There are about 15% of the people under the children under 200% in New Jersey who have yet to be offered S-chip, and yet what they'd like to do is increase it to 350% and take people who about 80% have insurance and move them over, and we think that's not a good idea. We think we ought to put poor children before we put better off children. And lastly, what was the last one?
It just seems like this is a bipartisan issue.
Listen, if this were just about the money, but it's not. This is about a very clear ideologic difference on where health care goes. And we believe health care...
Between whom? I'm sorry to interrupt.
Between those who believe that everybody ought to be insured by the federal government and those who believe that government has an obligation to organize a market where every person has access. And it is hard to defend, in my judgment, how the bill itself and the outcome of the bill itself can result in anything other than people being taken off private insurance and put on government insurance. Now, this is not adding substantially to the number of people who have insurance. It's adding greatly to the number of people who have government insurance, but not the overall problem. And my view is we need to solve the bigger problem and get down to that issue. All right, you've been terrific. Let me just close with this. I said early on, this is the kind of challenge that can change the economic equation of an entire country over time. It's already starting to. We're now in a global market, an entirely different competitive circumstance than we were 30 or 40 years ago. We've got to get better at this, or we'll be economically beaten. Now, when it comes to change in a global marketplace, it's not easy. But there are 3 ways that you can respond to it. You can fight it and fail. You can acquiesce to it and survive, or you can lead it and prosper. Now, this country has remained an economic leader because we have solved problems like this in the past. We've taken them on squarely, and we have solved them. I believe this challenge is this generation's challenge to solve. And we need to get down to it, because we can remain great, we will remain great, but the task for us is to find a way to solve this so we have better health and lower costs for all Americans. Thank you.
Secretary Leavitt, on behalf of Dean Coatsworth, I'd like to thank you for taking the time to visit SEPA today. It's a very important issue, not just to the faculty and students who are assembled here in the room, but to the nation. It'll be central to the election next year, and I think we've all benefited from the time that you spent with us. Thank you.